Psychiatric disorders. The objectives to describe the different characteristics of each type of anxiety disorder, mood disorder, and schizophrenia, identify the etiology of mood disorders and schizophrenia, identify classifications of each behavioral disorder, discuss dental anxiety and ways to prevent it in the dental office. So when we talk about psychiatric disorders, there are three main categories. We're going to talk about anxiety disorders, mood disorders, and psychosis. Anxiety disorders include phobias, panic attacks, generalized anxiety disorder, and post-traumatic stress disorder, or PTSD. Mood disorders include depression and bipolar disorder, and psychosis includes schizophrenia. Anxiety. So anxiety is a sense of psychological stress that may not have a focus, may not be able to pinpoint what's causing that anxiety. Psychological, it can be psychological, a feeling of sort of impending doom. You feel like you're on edge, you're irritable. It can also manifest physically with things like tachycardia, chest pain, indigestion, headaches. Sometimes people feel like their throat is sort of closing, like they have a lump in their throat. It can be a combination of any of these. Most frequent psychiatric problem in the general population is anxiety. So normal versus abnormal. For a person with anxiety disorder, the anxiety does not go away and it can get worse over time. The symptoms can interfere with daily activities such as job performance, schoolwork, and relationships. On the left, you can see not on the left, that's from my notes, but here on this slide, you can see some normal anxiety that might be associated with regular life. So here we can see worrying about paying bills, getting the job you want. You might feel embarrassed because something happens or feel socially awkward in a situation. Case of the nerves, if you have a big presentation, a realistic fear of something dangerous or a place or situation, anxiety, sadness, or difficult sleeping after a traumatic event. These are all things that would totally be expected under normal circumstances. But if you have an anxiety disorder, you have feelings of constant worry that causes significant distress and interferes with your daily life when there's really maybe nothing specific to be worrying about. Avoiding social situations for fear of being judged, embarrassed, humiliated. Out of the blue panic attacks with fear of having another panic attack. So the panic attack can be like a vicious cycle because you're afraid you're going to have another one, which kind of induces it. Irrational fear or avoidance of an object, place, or situation. Reoccurring nightmares, flashbacks, or emotional numbing related to a traumatic event. Within anxiety disorders, we have phobias. The three types of phobias include agoraphobia, social phobias, and then specific or simple phobias. So agoraphobia, you have to have at least two of these: using public transportation, being in an open space, being in an enclosed space, standing in line or being in a crowd, being outside of the home alone. Social phobia, people with social anxiety disorders have a general intense fear or anxiety towards social or performance situations. And then a simple phobia would be something very specific, like you have a fear of flying, a fear of heights, a fear of spiders, fear of getting a shot or seeing blood. Those are simple phobias because they are very specific. People with panic disorder have recurrent, unexpected panic attacks. Panic attacks are sudden periods of intense fear that come on quickly and reach their peak within minutes. Attacks can occur unexpectedly or can be brought on by a trigger, such as a feared object. And you notice, like we said before, you can have all of these physical feelings or manifestations from a panic attack, and it lasts several minutes. And one thing that helps a lot of people in understanding panic attacks and what can sometimes help people deal with them overall is knowing that they can't just go on and on and on. Like your body kind of becomes exhausted after, 20 minutes, maybe max. And those intense feelings of sort of like you feel like you're about to die or something, they have sort of a window that you have that feeling, and then your body has to kind of um, ratchet back down or calm back down. So it's not like a panic attack will go on for hours. It's usually max 20 minutes, and then you'll start to feel better, which is kind of a nice thing to know that it will end sooner than later if you're having panic attacks. Anxiety disorders include post-traumatic stress disorder, psychophysiological symptoms, and symptoms that occur after exposure of a traumatic event. You see this a lot with people who have been in, something horrible like the 9/11 terrorist attack on the World Trade Centers, or anybody that's in the military that's been in active duty or war. Even people who were close to, something like a major natural disaster, a hurricane, tornado, Mount St. Helens erupting, if they lived close and it was, very violent and scary, they can have post-traumatic stress because of all those different scenarios. So we have to be very aware of our fearful patients. They could be just a little nervous, need some extra TLC, or they may need to be medicated. And it's important to realize that patients will act very different. A fearful patient could appear very grumpy. A fearful patient could appear super talkative. A fearful patient could come across as very quiet and aloof, not very friendly, or overly friendly and like overly talkative. So fear in the dental situation can manifest itself differently, and we just have to be very empathetic and aware. And if we have a patient that is coming across a certain way, that we don't judge them as just being a rude person or a grumpy person or a difficult person, but somebody that potentially has a fear that we as the healthcare provider can help to alleviate so that their dental visit is positive. Dental anxiety, 9 to 15% of Americans avoid seeing the dentist because of anxiety and fear, and 30 to 40 million people is what that percentage represents. So it's a large group of the population. Sometimes it's older people because they went to the dentist back when, maybe local anesthetic didn't work so well, or maybe they didn't get local anesthetic at all, so who knows, or maybe they had a very impatient or, not very empathetic healthcare, dentist or hygienist that didn't heed the signs that they were saying, this hurts, and they did nothing. They showed no caring to them, or, they had a bad experience as a child or, a number of different situations. In a survey by the British Dental Health Foundation, 36% of those who didn't see a dentist regularly said that fear was the main reason. Dental anxiety usually stems from a fear of pain, would of course be your main reason. Feeling of helplessness or loss of control, you definitely feel that when you're laying in the chair and you're opening up a very sensitive part of your body and you don't really have control of what happens. It certainly can make someone feel uncomfortable or fearful. People may be embarrassed about their lack of care in the past and not want to feel judged, or if they've had a negative past experience. And what can we do to help ease anxiety? Well, like we talked about before, or just a second ago, we can do a lot by just the way we handle our patients, just the way we talk to our patients, listening to our patients, finding out what part of the appointment is scaring them. Let them say their piece, give them some control. If they feel that they have no control, give them the old raise your hand if anything is uncomfortable and we'll stop, or anytime you need to take a break, we can do that. or, whatever it is, but just listening to them and then addressing their fears usually goes an extremely long way. Okay, mood disorders characterized by extreme exaggeration and disturbance in mood tends to be cyclical, or in other words, seeming like a mood swing, happy to severely depressed. Two main categories, there's depression, major depression, persistent depressive disorder, or dysthymia, and then there's bipolar. So major depression, it includes symptoms of depression most of the time for at least 2 weeks that typically interfere with one's ability to work, sleep, study, and eat. Persistent depressive disorder, dysthymia, which often includes less severe symptoms of depression, but it lasts much longer. So typically it can last for years. So major depression is sort of intense and a shorter duration. And then persistent depressive disorder or dysthymia tends to be milder, but lasts longer. So 5 to 10% of the population, and that actually may actually be higher now. I should have probably looked up, because since we've gone through COVID, a lot of these numbers have increased some. But this was probably maybe a number from maybe 2 years ago. So usually the numbers tend to stay pretty stable, but just going through COVID, and recently there's been an uptick in mental health disorders. So that may be slightly higher now. But possible causes: decreased level of norepinephrine, serotonin, and dopamine. Serotonin is an inhibitory neurotransmitter that we've talked about that has been found to be intimately involved in emotion and mood. There's also genetic predispositions, incomplete psychological development, or loss, trauma, loss, something like that. Really interesting studies have come out that have shown that antidepressant medications really don't work the way that they think they have. They've claimed, people who are depressed oftentimes have just almost like they're deficient in serotonin or something like that. And while it is true that many people get benefit from taking like SSRIs and stuff and different medications, they have published numerous studies that are showing that it's not specifically because of low serotonin. And I think that what it a lot of times boils down to is it's a mystery. Like, it's still a mystery as to what's going on in the brain and why people are more prone to depression than others. But you can always look into this further. But at the moment, that is what a lot of the medications are. They work on the neurotransmitters and trying to keep the sort of feel-good neurotransmitters available for the brain. And our guest speaker will talk more about that topic. So here we have sort of a little diagram that kind of highlights this. It's known that biochemical imbalance occurs in depression. That's in the notes there, but I think that is debatable, even amongst, pharmacology experts and psychological, psychiatrists and people who are experts in this field. There is quite a bit of debate there still. However, that is what a lot of the hypothesis has been based on, that there's a biochemical imbalance. Either there's an increased breakdown of these neurotransmitters by enzymes, or there is a decrease in their synthesis in the presynaptic neuron, possibly due to the reuptake. So maybe, it's taking up too much. It's keeping it so that this little reaction where the serotonin is released and the receptors grab the serotonin, something in that is making it so not as much serotonin becomes available. Maybe it takes it up too quickly, or it just doesn't produce as much. There's still a lot of, they have to figure that out still. But a lot of the theory has been that there's just simply not enough serotonin available, and that's what's leading to some of these depressive states. In any case, there is a reduced level of norepinephrine and serotonin in the neural synapse junction. So this is the junction where those neurotransmitters would be hanging out, trying to get to the other side of these receptors. This is the chemical name for serotonin, this 5-HT. So with depression, like we kind of mentioned this in an earlier slide, classified as major depression, it's the most common. Those are those significant bouts of depression that are more short-lived. And then there's the persistent depressive disorder, or dysthymic, which is a milder form, but it lasts longer. Depression, not otherwise specified. Maybe it doesn't easily fall into these two categories. 20 to 25% of women, 7 to 12% of men experience major depressive episodes at some point. And there's also seasonal depression and postnatal depression. Some symptoms that go along with depression. There is, for major depression, you have to have at least 5 symptoms that have been present during the same 2-week period. Depressed most of the day, loss of interest in most activities, significant weight gain or loss, insomnia or hypersomnia nearly every day. So either they can't sleep or they sleep too much, fatigue or loss of energy nearly every day, psychomotor agitation, feeling of worthlessness or guilt, inability to think or concentrate, recurrent thoughts of death. Dysthymia, the more milder form that lasts longer, depressed mood for most of the day for at least 2 years with presence of 2 or more of the following. So they have only 2 or more of these: poor appetite, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, feelings of hopelessness. So now we'll talk a little bit about bipolar disorder specifically. It's a chronic or episodic, which means it occurs occasionally at irregular intervals, and it's categorized as a mental disorder. It can cause unusual, often extreme and fluctuating changes in mood, energy, activity, and concentration or focus. Bipolar disorder sometimes is called manic depressive disorder or manic depression. Those are older terms. Usually you just hear bipolar these days. Manic episodes must have symptoms for at least a week. So for a solid week, there is an elevated mood or an irritable mood, an increased aggressiveness, almost maybe a euphoric, like they're just like crazy, happy and bouncy and creative for like just always, like they're always on for like a week. Very impulsive behavior, not feeling like they need sleep, just busy, increased activity, grandiosity, exaggerated sense of self-importance. Really interesting. A lot of very creative people actually have bipolar disorder, and if you kind of do some research into it or watch some documentaries on it, you'll hear many people say that they actually love their manic episode because their most creative things or their most productive things come out of this manic phase where they just feel like uber, productive and creative and on and up. And medications, of course, dampen this. Medications, take this away, and they actually like don't like that part of it because they see some, positive benefits to this sort of stage where they're just up and, super active. Of course, on the swing side is the depressive episodes, which don't have a lot of positive at all for at least 2 weeks. They'd have 5 or more of these symptoms occurring either all day or at least for the majority of the day, feeling sad, decreased interest, low self-esteem, sleep disturbance, appetite disturbance. And of course, that's a huge swing from the, everything is like exciting and up and energy, and then to just be like, oh, everything's awful and there's no energy. And they, so it's a huge swing, right? That's why it's called bipolar. Mixed episodes characterized by both mania and depression, highs and lows over a 1-week period. So that's a different type of bipolar where they're just like bouncing, like, this is great, this is awful, this is great, this is awful. Just a major up and down swinging. Then there's different classifications of bipolar. If they're classified as bipolar 1, you're considered the sort of classic form of the maniac, the manic, not maniac, but manic and depressive. Hypomanic or mixed state can occur. There must be a full manic episode for a diagnosis of bipolar 1. So there must be this full swing of very distinct up and then a very distinct down. Bipolar 2, at least one hypomanic episode and at least one episode of major depression. Patients never experience a full manic episode, so there just may be manic type displays, but not the full manic episode. Cyclothymic, chronic episodes lasting more than 2 years. Many periods of mild hypomanic and depressive episodes occur, does not meet the criteria for either mania or major depression episodes. So cyclothymics is almost, you can think of it maybe more like sort of like, or maybe a milder form of bipolar disorder lasting longer. You don't have those extreme highs and lows in a shorter period of time. Bipolar disorder, not specific. Category that refers to bipolar disorder symptoms that do not match any of the recognized categories. So maybe somebody has similar symptoms that seem bipolar, but they don't fall into the total category. So they're not diagnosed bipolar, but maybe there's things that are similar. So here's just another breakdown of it with the mood disorders, bipolar, and then depressive. With depression, there's major, dysthymic, and non-specific. And then for major depression, you can have either a single episode or it can be recurrent. For bipolar, you have the kind of the classic bipolar, bipolar 2, the cyclothymic, which you can kind of think of as similar to dysthymic, and then non-specific. With bipolar 1, there's the manic, the mixed, and the depressed. And then with bipolar 2, there's the hypomanic and the depressed. I think that's a typo. I'm not sure what that is. Okay, so mood disorders for the treatment, of course, our guest is going to talk to us about treatment. 2 prolonged approaches for most effective: psychotherapy or counseling. There's a lot of positive studies referring to cognitive behavioral therapy. Studies have shown, exercise and lifestyle changes to have a huge impact on depression and anxiety. There is, of course, pharmacological therapies that, whether it be long-term or short-term, can show some positive effects for sure. Other treatments that they've used in the past, electroconvulsive therapy, electric shock therapy, regular vigorous exercise. Numerous people will say exercise is a massive positive effect, has a major positive effect on both anxiety and depression. Keeping a life chart, which records daily mood symptoms, treatments, sleep patterns, and life events, can help people and their doctors track their and treat the bipolar. Journaling, cognitive behavioral therapy. There's so many different diet. Sometimes people find that a huge diet change, reducing sugars and caffeine and things like that can have a major positive effect as well. All right, now we're going to shift to schizophrenia here. Schizophrenia is a disordered thinking, inappropriate emotional responses, hallucinations, delusions, and bizarre behavior. Most common type of psychosis is the schizophrenia. Affects only approximately about 1% of the population. So thankfully, it's not a huge percent. Etiology is unknown. Neurotransmitter affected. There's too much dopamine produced in the brain. So this is one component that they have an understanding of, is if there is, we know that Parkinson's disorder, right, is too little dopamine. Well, the flip side of that is if there's too much dopamine, you can start to have some of these negative effects here. Chronic stress of poverty. So some of the risk factors for schizophrenia. Chronic stress of poverty. Approximately 200,000 individuals with schizophrenia or bipolar disorder illness are homeless. constituting 1/3 of the approximately 600,000 homeless population. And that's per the Department of Health and Human Services. Triggers in susceptible individuals is drug use. You find that to be huge hand in hand. People on the streets who are schizophrenia or have bipolar oftentimes have a drug problem. Genetic predisposition, medical illness, stressful psychological events, viral infections, and family conflicts. These can all be triggers. And our guest will talk about this, but we have with schizophrenia, there are two kinds of symptoms. There's what they call positive symptoms, and then there's what they call negative symptoms. So you can think of it as positive symptoms. These symptoms are really obvious and they're present, like you see them, and that's why they call them positive. So hallucinations, the person is clearly acting weird, they're hallucinating, or they have delusions, or they're paranoid, or they have very disorganized behavior. These are all kind of symptoms that the outward population can observe of someone with schizophrenia. Then there are the negative symptoms, which means they have a lack of some normal things that people, like normal healthy people, might have. So they have a lack of emotion, a lack of speech, and a lack of motivation. So those are almost like taken away from normal behavior, where this is like added abnormal behavior. For pharmacological therapy, if you were an antipsychotic drug, would you be an antagonist or an agonist for dopamine, and why? So per the slide that we saw before, people with schizophrenia seem to have too much dopamine. So we want to be an antagonist, right? We want to maybe block some of that dopaminergic receptors so that they don't have as much dopamine in their brain, right? Which disease is a result of not enough dopamine? Well, I already said that earlier. But we know that people who have Parkinson's have the opposite problem. They don't have enough dopamine. And so with drugs like levodopa or carbidopa, levodopa, carbidopa, we're trying to get dopamine into the brain. Oh gosh, that's it. That's as much as I'm going to talk about. So hopefully you'll watch this before our guest, and we talk about it more in class.